we are going to talk about endotracheal intubation. For today's case, a senior clerk on duty at the emergency room was tasked by the resident on duty to perform the endotracheal intubation with his guidance. She was given a 20-year-old female patient who came in due to difficulty in breathing. Patient was a known asthmatic with maintenance medication of albuterol. Patient has a history of exposure to a COVID-19 positive boyfriend. Vital signs were the following: BP of 80/40 mmHg, pulse rate of 120 beats per minute, a respiratory rate of 20 cycles per minute, temperature of 38 degrees Celsius, an O2 saturation of 89% at room air. How to do the intubation process? Because we are having a suspect COVID patient, we must always protect ourselves first by having a complete PPE. According to the WHO, the PPE used when dealing with a suspect COVID case with an aerosol generating procedure, you need to have your eye protection, filtering respirator, gown, medical gloves, and apron. Before the intubation, you should first look externally for deformities, short neck, or any other features that may predict a difficult airway. Next, evaluate using the 3-3-2 rule, where you should be able to fit 3 finger breadths within the mouth between the incisors and 3 finger breadths from the tip of the mentum to the hyoid bone, and 2 finger breadths between the hyoid bone and thyroid cartilage. After that, check the Malampati score. The best way to assess the patient is when she's seated upright with the head neutral, mouth open, trunk protruded, and no phonation. But remember that the higher the grade, the difficult it is to intubate. Check for any obstructions such as masses or any hematomas forming. Lastly, for neck mobility, check if the patient can flex or extend his neck without difficulty. For the intubation, materials should be prepared. For the monitoring of the patient, prepare a cardiac monitor and pulse oximeter. For the airway, prepare the following: suction catheter. Prepare an oropharyngeal airway. For the laryngoscope, use the curved blade because we are dealing with an adult patient. Then the tracheal tube with a 7 mm in diameter. Check its patency by an empty 10cc syringe to inflate the cuff. If there is no leakage in the cuff, then deflate it again. Because I'm using a stylet, remember to insert it up to the point beyond the cuff, but not beyond the opening. And also prepare a plaster and stethoscope. Prepare the IV fluid and the drugs. So for this patient, she is already hypotensive, tachycardic, and also asthmatic. So the sedative given to this patient is ketamine 4.5 mg per kilogram via slow IV injection over 60 seconds. Prepare also a muscle relaxant succinylcholine 1 mg per kilogram IV. While the materials are already prepared, place the patient in a sniffing position by putting a pillow under her head. This would provide a cervical flexion about 30 to 35 degrees. Then use a suction catheter to clear the patient's airway for any foreign materials or secretions. Let's do pre-oxygenation. First, open the airway using the head tilt chin lift maneuver. Then place the ambu bag on the patient's face. Make a tight seal, making sure it does not leak. Thumb and index finger is in C position, while the rest of the 3 fingers is under the mandible for a chin lift. Sellick's maneuver is done by external pressure, about 1 kg pressure at the cricoid ring against the vertebral bodies to occlude the esophagus. The constant pressure is maintained until the endotracheal tube is appropriately placed with the cuff inflated. Administer ketamine and then succinylcholine. To start with the intubation process, again, the patient is in a sniffing position and neck flexion with the cervical occipital extension need to align the oral pharyngeal and laryngeal axis. Elevate the table to avoid bending over. Scissored thumb and index finger of the glove right hand touching the right mandibular and maxillary premolars is needed to do to open the mouth. Hold the laryngoscope using the left hand with the 5th finger close to the hinge and the handle pointing right to the sagittal plane. Introduce the blade along the right margin of the tongue, displacing it towards the left. Advance the blade until the right tonsillar fossa is identified. Medial to the tonsillar fossa, locate the epiglottis. Advance blade to the midline glossoepiglottic reflection. The tip of the blade should be placed in the vallecula and lift the laryngoscope upward to lift up the glottis. Then pass the endotracheal tube with the stylet from the right, keeping it from blocking the view of the glottis. Advance the tube until proximal margin of its cuff lies 3 to 4 cm beyond the vocal cords. Inflate the cuff with 10 cc of air. Remove the laryngoscope then remove the stylet and connect the endotracheal tube to the breathing circuit. Check by auscultation of the lungs for equal breath sounds. If there is equal breath sound, secure the tube in place by using the plaster. But what happened to the case is that intubation, the resident double-checked the tube placement, since upon bagging, gurgling sounds on the abdomen was noted on auscultation. The patient became cyanotic and oxygen saturation decreased to 84%. What should we do next? So first, deflate the pilot balloon and extubate. Go back to pre-oxygenation and do bagging. Remember, oxygenation is very important. Make sure the patient is stable enough before attempting to do the endotracheal intubation again. Stay tuned for the next episode. Thank you.